urinary calcium excretion rate. So let's move on to calcium phosphate stones. By some estimates, this would be about 15% of the stones that you will encounter as a nephrologist. Again, we still have hypercalciuria as being a prominent factor in the pathogenesis of this variant of stone disease, but we have a different equilibrium reaction. You'll recall that for calcium oxalate stones, we have the equilibrium reaction represented here, calcium plus oxalate forming calcium oxalate. And so we have a different equilibrium that is center stage, calcium plus a divalent phosphate forming calcium phosphate. Okay, now similar to our discussion around calcium oxalate stones, one way in which we can compete with this equilibrium reaction is to pull calcium over to an alternate destination. And that would be through citrates interaction with calcium, right? So calcium citrate would reduce, or the presence of citrate will reduce the availability for calcium associating with phosphate and forming the less soluble calcium phosphate. So hypocitraturia is certainly another factor that's relevant in the calcium phosphate stone former, okay? That is often especially true because many of these patients with calcium phosphate stones have either overt or subclinical metabolic acidosis. You'll recall why metabolic acidosis is important in rendering the urine hypocitraturia, right? We've gone over the pathophysiology of that. The increase in apical transport of citrate in the setting of a urinary lumen that is more acidic, the upregulation of proximal tubular enzymes like citrate lyase in the setting of metabolic acidosis, all conspiring to reduce the urinary citrate excretion rate. So again, two reasons why this is relevant is, again, calcium phosphate stone formers may have RTAs or incomplete RTAs that reduce the urinary citrate content. Now, finally, and let's call it most importantly, alkaline urine is part of the pathogenesis of most calcium phosphate stone formers. Sometimes it's just kind of mass transport, meaning a primary hyperparathyroidism that manifests with calcium phosphate stones. But often there is either subtle or overt, either subtle or overtly alkaline urine, okay? Because calcium phosphate is less soluble with higher urine pH, right? Less soluble with higher urine pH. Why does that happen? Well, it is the case that when you have an alkaline urine, you have more of the divalent form of phosphate, right? It can be trivalent, right? Phosphate has a -3 charge. So when I have alkaline urine, I then shift this equilibrium reaction towards the right? I create divalent phosphate, right, compared to the monovalent phosphate, and a proton that is now either free or bound with bicarbonate, okay? So again, I'm pushing the reaction to the right. The more alkaline my urine, this divalent form of phosphate can more efficiently associate with calcium, forming the less soluble calcium phosphate. Okay. A word about pKa. It will come up in your Orson Mo lectures. pKa refers to the propensity of a solute to dissociate into a free proton and its conjugate base. At the pKa, we have equal portions or equal amounts of the protonated and ionized forms of the solute in question, okay? So that is to say, when I have a pKa of around 6.7, I would have equal proportions of this monovalent form of phosphate carrying 2 protons and this divalent form of phosphate carrying 1 proton, okay? This will come up in your lectures. pKa's is sort of a concept that you've studied long ago. It's going to be especially important as we're talking about kidney stone, and then also the acid-base lectures, okay? So the more alkaline the urine, I'm on the right side if I'm visualizing a pKa gradient. I'm on the right side of this pKa, and I'm shifting towards this side of this equilibrium reaction. Okay, again, at a pKa of 6.7, there will be equal amounts of divalent phosphate and monovalent phosphate. Everybody get that? Okay. All right, so distal renal tubular acidosis, again, either overt or incomplete forms of renal tubular acidosis are this major predisposing factor for calcium phosphate stones, again, through the effect on urinary citrate excretions, as well as the solubility of calcium phosphate. A known risk factor that comes up not uncommonly is an acquired problem with urine acidification through the administration of carbonic anhydrase inhibitors. A common drug that you'll encounter is topiramate, either through weight loss, I guess, which is less common with the prevalence of GLP-1s now, but is still used for weight loss, migraine prophylaxis, and even some seizure disorders. This would be a scenario in which you might see as a presenting feature of mild metabolic acidosis, the formation of a kidney stone. Zonisamide is another carbonic anhydrase inhibitor that you might encounter. In that case, it's often used for GI disorders. Okay, so let's then move from calcium phosphate, which, by the way, is the most difficult stone that you will be, well, one of the most difficult stones that you'll be managing. I suppose there's a lot of hard struvite stones for recurrent UTIs and cystinuria, but calcium phosphate stone formers are much harder to manage than calcium oxalate stone formers. I guess I'll put it that way, okay? And uric acid stone formers, segueing, are the easiest to manage, okay? So that should be a success story in pretty much every patient that you see, as long as you have compliance and engagement and you've got your thinking caps on in managing these patients. I've alluded to this previously, and I'll reemphasize it now, that uric acid stone formers are not the result of hyperuricosuriasia. That is not the main factor at play in the uric acid stone former. Sort of reflecting, or the inverse of the calcium phosphate stone former, where alkaline urine is the primary, or is one of the primary problems. In this case, with uric acid stone formers, an overly acidic urine is the main factor, pathogenic factor. Okay, it's not so much a disorder of hypouricosuriasia. All right, now, in this scenario, you can hopefully appreciate another equilibrium reaction where urate, the conjugate base, and proton is on one side, and then the protonated form, I'll call uric acid, contrasting with urate, referring to the conjugate base, is on the other side of this equilibrium reaction. Okay, urate is quite soluble. Okay, uric acid, on the other hand, is less soluble. So if I have a acidic urine, right, I have a surplus of protons, I would be pushing this reaction towards the right side of this equilibrium, forming more uric acid, which is less soluble. Okay, you can see that uric acid is markedly less soluble than the urate anion. So you can have astronomical amounts of uric acid in your urine, or urate/uric acid in the urine. If you have less protons, that is an alkaline urine, you will be able to solubilize most of that uric acid, okay? Uric acid / urate, all right? And you will not form stones. Unlike the calcium stones, uric acid stones you can actually dissolve. So a calcium or a calcareous stone can either be passed or uh, um, silent and non-growing. Okay, that's success in the calcium oxalate stone former or the calcium phosphate stone former. Reduce the growth of stones, keep them clinically quiescent so that such that they don't cause morbidity. That could be a measure of success. On the other hand, uric acid stones can be dissolved, and you can essentially eradicate the stones present, even if they don't pass them. Okay, so our goal is to alkalinize the urine, but not go too far, because one can try to alkalinize the urine, or at least make it less acidic, and then create another monster where you've reduced the solubility of calcium phosphate. The same can happen as you treat a calcium oxalate stone former with too much potassium citrate. So this story exists where the overuse of base in the form of sodium bicarbonate or potassium citrate can create a different monster, the calcium phosphate stone former. Okay? Recall or think that uric acid stone formers don't need potassium citrate per se. You can reasonably treat a uric acid stone former with sodium bicarbonate. Okay. In general, we try to use potassium citrate because we want to limit the sodium load. Sodium loading can perhaps increase urinary calcium excretion rates. So in general, we lean towards potassium citrate even in uric acid stone formers, but there are reasons you may not want to. Their potassium may be on the high side. They may have a dyspepsia with the potassium citrate, or it may be more expensive. You can put a patient with uric acid stone formation on sodium bicarbonate or baking soda and manage them that way as well. Okay. Now, factors that increase the or make the urine more acidic are high protein diet, right? High protein diet is an acid load and so can predispose to more aciduria. Diarrhea is another factor that can predispose to uric acid stones. In fact, I would say that, ileostomies are some of the clinical context in which you find uric acid stone formers. Patients who have large amounts of base loss in the stool, right? What does that do? It tends to reduce urine volume, or base loss in the stool makes your acid uric, right? And then the volume loss in the stool contracts urine volume. And so the perfect storm exists, right? Low urine volumes, chronic aciduria, and now uric acid stones, right? You'll also recall, I'll leave it at that. So again, ileostomies are scenarios in which you can find uric acid stones. You can also see patients getting calcium oxalate stones in ileostomies as well, because loss of base in the stool will tend to cause metabolic acidosis, which will cause hypocitraturia, and low urine volume will increase the propensity for kidney stone formation, calcium oxalate as well. Okay, but you won't tend to see calcium phosphate stones in a patient with an ileostomy, right? Because they're going to tend to have aciduria. All right. Obesity is another main factor for the uric acid stone. And some of that work has been done, basic science has been done at UT Southwestern, where in certain patients, as well as animal models of obesity, you can see disorders of ammonia handling in the proximal tubule. And some have espoused that you might have actually an accumulation of fatty acids in the renal cortex, and that be a sort of a microscopic um, picture of a disease process going on in the proximal nephron with energy metabolism. So there's an alteration of energy metabolism in the proximal tubule. one manifestation of which is reduced ammonia production by the proximal tubule. Okay, why would reduced ammoniogenesis predispose to acidic urine? Right, so pH is a function of free proton concentration, right? Free proton concentration determines the proton concentration is your determinant of pH, right? pH is a negative log base 10 transformation of proton concentration, right? So if I have urinary buffers, including plenty of ammonia in the urine, then my free proton concentration is reduced. So I will have less acid urine if I have sufficient ammoniogenesis. So reduced ammoniogenesis would predispose to aciduria. Okay. Again, your hyperuricosuriia is not the major factor. It is a factor, but is not the major factor at play for uric acid stones. Moving on to struvite stones. This is now we're getting into the single digits: struvite stones, cystine stones, in the types of stones that you're going to encounter. When we see struvite stones, magnesium, ammonium, phosphate stones, we think of these being the end result of a UTI with the urease expressing organism. Okay, what happens when a bacteria expresses urease? Well, you split urea into bicarbonate and ammonium. Okay, bicarbonate and an ammonium. Okay, so what might you see? You'll see astronomical urinary ammonium excretion rates in the urine, right? When you do a 24-hour urine stone risk panel at UT, you don't get these at Parkland. You will get an ammonium excretion rate as part of that panel, okay? And you will see huge amounts of ammonium in the urine. Normally, you should see maybe about 30 millimoles of ammonium in the urine, something thereabouts, right? Let's do the math in our head. Remember, I told you that roughly in the typical Western diet, you're going to excrete about 1 millimole per kilogram of non-volatile acid in a day. 50% of that roughly is going to be buffered by phosphate. The other 50% is going to be buffered by ammonium. Okay, so you might see ammonium somewhere around 30, 50 millimoles would be, roughly half of 70, right? Okay, so in patients with, struvite stones, you'll see ammonium excretion rates that are like 100 millimoles or higher than that. Where does all that ammonium come from? Not from the kidney just cranking out urinary buffer, but rather the splitting of urea into ammonium and bicarbonate. Okay, the presence of bicarbonate would predict that would result in an alkaline urine, and this ammonium phosphate salt is going to be less soluble in that alkaline urine. Okay, so that's the pathogenesis at play for the struvite stones. Usually this is, again, the result of a bacterial urease and resulting in a perfect storm here. Okay. Moving on to cystine stones, this arises from a metabolic or a transport defect that occurs in the proximal nephron. So you have a transporter of amino acids in the proximal nephron that can be mutated in individuals with cystinuria. This is a transporter, or let's say a transporter with multiple subunits that transports divalent cationic or cationic amino acids. Okay, so cysteine, these are your cola, right? This is arginine, lysine, cysteine, ornithine. Cola referring to a variety of amino acids. So you'll have wasting of all of those amino acids in the urine, but the only one that's particularly relevant is the cysteine. The cysteine is the one that is less soluble in its dimerized form. Okay, so I'm going to have high urinary excretion rates of all of these amino acids. Again, cysteine is the most relevant form. Okay, so again, this is an inherited defect of a proximal tubular transport protein. It has complex genetics. Some have described recessive pattern of inheritance, dominant pattern of inheritance, and incomplete penetrance, right? That means you may have the genetic mutation, but one of your family members is forming kidney stones and the other is not, right? That's the definition of incomplete penetrance. So you can see it's quite complicated in its genetics, and so doesn't always have a strong family history present. And Again, the problem results when cysteine dimerizes with itself, okay, and that forms an insoluble salt. The presence of an acidic urine makes it further insoluble, okay, and there's obviously a concentration dependence on this salt precipitating out of solution. Okay, so there's several factors to sort of appreciate here. So cysteine dimerizes with itself, right? Cysteine is the dimerizes with itself, forming this cysteine that differs by in spelling here. This is the less soluble dimer of the amino acid. It is less soluble at acid urine pHs, and of course, there's a concentration dependence. So that will be relevant. These parts of the pathogenic steps will be relevant as we talk about treatment. I'll anticipate that. We often use things like potassium citrate to make it more soluble. We increase urinary volumes so that the concentration is less. And then we also compete for this dimerization by using thiol binding drugs, right? Things like even captopril is penicillamine were old drugs that were used to compete for this dimerization. And now we have other tools as well. Okay, so high protein intake favors cystinuria because you'll recall that animal proteins have higher content of cysteine in it. And that's one of the reasons why this is modified by high protein intake. The disease is modified by high protein intake. That animal protein would also tend to reduce the urinary pH, make it more acidic, reducing the solubility. And Similar to the calcium oxalate stone former and the calcium phosphate stone former, there's a dependence of cysteine excretion rate on sodium intake. And maybe this is simply the familiar effect of volume expansion on mass transport in the proximal nephron, including transport, including this transporter. Okay. Notice again that there are again these two subunits that have this very wonky nomenclature, RBAT, and this other hard to say form or subunit of the apical transport protein. You can have mutations in either one of these subunits and present with cystinuria. Okay. All right, so moving on to diagnosis and treatment. I think I'll be fairly brief about diagnosis. Many of these patients have hematuria. In the acute setting, that is a very sensitive finding when you present with renal colic, but that becomes less prevalent as you get further from the initial presentation. Imaging, we typically rely on CT scan as being the most sensitive and specific for kidney stones of all types, okay, including uric acid stones. KUBs are really or really only helpful for calcareous stones. Uric acid stones, cysteine stones would be will be transparent on KUB. You can still see those stones on CT scans, however. Okay. Ultrasound is something that we sometimes use, especially in certain populations where radiation would be less desirable, and then also in the serial monitoring of your patients. So, as you manage patients in the kidney stone clinic, you're going to be evaluating them based on history and imaging as a measure of success. You're asking them, did you have a kidney stone in the last 6 months since we saw each other? Did you pass a stone? The answer is no. Okay, that's good. But you don't know whether that's still success. You have to do some form of imaging to reassess the burden of kidney stones. If they're increasing in size and number, even though the patient is asymptomatic, that is not a success. Okay? So again, ultrasound and CT imaging are part of the management of a kidney stone patient. You obviously want to be modest in redosing your patient with all of that radiation. My personal practice is to do CT scans roughly every 2 years for the patient with recurrent stones, not for the patient with a single stone. For recurrent stone formers, it's going to be every 2 years of CT imaging. And then on the off years, I'm either doing ultrasound or KUBs to assess stone burden. Okay. Realizing that those are not great tests, I'm looking for big, obvious changes. Okay. Ultrasound and KUBs are not very sensitive at all. Okay. The workup can have a different, philosophy depending on how aggressive that you want to be in the evaluation. I think everyone with a kidney stone, even one kidney stone, should have at least a basic workup that includes looking for RTAs with a BMP, looking for uh, any primary hyperparathyroidism, since that's so common and kidney stones can be a presenting feature of that endocrinopathy. Looking at urine pHs to put in context the BMP if it's an incomplete RTA, the UA as well. Okay. The more complex evaluation, that is with 24-hour urine stone analysis, that should be certainly done for the patient who has recurrent stones. If you have a calcium phosphate stone, and if you have other malabsorptive syndromes, young patients who present with kidney stones, those are individuals where doing a more thorough workup with a 24-hour urine would make sense. Okay. I've included struvite stones. Those generally are not that, it's not that important to do the 24-hour urine, but you're going to at least be evaluating for, anatomic disorders, recurrent UTIs. So I'm including that as a part of a complex evaluation. All right. Again, if you have a first uncomplicated stone, it probably doesn't need to be pursued with 24-hour urine testing. A highly motivated patient might want that and may not be unreasonable. But, if you have a typical, middle-aged male with Caucasian with a kidney stone, doing a 24-hour urine is going to be a lot of information that can certainly affect lifestyle without clear benefits, right? If you give somebody they find that they have hyperoxaluria and they have, high sodium intake, and, you might see a low citrate, you might be anxious to give them potassium citrate. You may be anxious to try and take a lot of things out of their diet, including the okra that they like, right? Or whatnot, without clear gains in those patients, where maybe all you needed to tell that patient is, yeah, you had a first kidney stone, you got your typical risk factors, just keep drinking a lot of water and hope let's not get another stone. Okay, that would be a reasonable, more conservative approach. All right, stone analysis is something that is not always available. I would say it's commonly unavailable to you, and that you have to assume that you're dealing with a calcium oxalate stone just by the numbers. Or, you have someone who has, let's say again, ileostomy, or recurrent UTIs, you're going to use your brain without necessarily having a kidney stone in hand to do a stone analysis in order to make certain presumptions about what type of stone they have. The 24-hour urine stone profile, we've already kind of reviewed what all it has in it. As I mentioned, the Parkland stone profile does not include an ammonium, but the UT Southwestern one does. And you know, let me, I've stated it once. It's not, you get a lot of information out of a 24-hour urine, whether that's all that helpful, including the supersaturations. You should not be a slave to that. Okay, we have to admit that the 24-hour urine is not a perfect test. And even if you look at it a very, let's say, fundamental way, if you look at somebody's 24-hour urines, over time without any clear dietary changes. So there was a study that looked at paired samples of 24-hour urines that were done like within days of each other, a week of each other, and to look at the discordance of calcium excretion rates, citrate excretion rates. It was quite significant, right? It was the predominant paired urine, 24-hour urines had, let's say, greater than 30% variance in relevant solute excretion rates. Okay, greater than 30%. There was a fair number that had greater than 50% variance in excretion rates of certain solutes that you would be pursuing as a stone, as a nephrologist managing stone disease. So the point I'm trying to make is this is not a perfect test. You try to you create perfection by saying at least do it properly, right? Give them counsel on how to do a 24-hour urine, and don't game the system. Don't act differently around the time of your 24-hour urine. I don't get them around Christmas and Thanksgiving when you're doing something different with your diet. Don't do them in the hospital. I've seen people get 24-hour urines in the hospital. Those don't make sense. Okay, you should do it on their routine lifestyle, and then even then, it's not a great test. Okay. Urine microscopic analysis ideally should be done if you have somebody with a family history that might imply the possibility of cystinuria. And, looking for the classic hexagonal crystal is sufficient to make the diagnosis. If you don't have that, then you can do a 24-hour urine cysteine looking for that excess excretion rate of that solute. Okay. Moving on to treatment I guess I'll say something briefly about the symptomatic renal colic phase. NSAIDs are as effective in randomized controlled trials as opioids without the downsides. Spontaneous stone passage happens in a lot of the patients. It's a function of the size of the stone and its position along the ureter. Okay? So size and location along the ureter are main factors in predicting the likelihood of a stone passage. Okay. And once you get to a centimeter stone, okay, that's when the likelihood of passage is significantly low. Okay. But once you're in this less than 5 millimeter range, right, you're having pretty reasonable rates of stone passage. Okay. All right, so we can use things like tamsulosin to help with some of these 5 to 10 millimeter stones. It has shown to have some benefit with stones of this size. Stones smaller than this are going to pass regardless in many cases. Stones larger than this are not going to pass even if you use your tamsulosin, okay? And again, if you have stones that are further along, right, close to the bladder, the ureterovesicular junction, those are more likely to pass. And it's less likely to pass if it's in the proximal ureters. Okay, so that's what the urologist is using to make a decision on. Sometimes you're going to be at the front line and you're going to be starting the tamsulosin. So it probably makes sense for you to be armed with this knowledge as well, even though you're not a urologist. Okay. And then if somebody has these features, big stone, acute renal failure, like a kidney transplant patient with a stone is going to have kidney failure. infection with stone. These patients these are emergent urology consults. Okay, and so these patients often get a percutaneous nephrostomy tube to decompress the infected urinary tract before they have their definitive therapy. The other thing that you'll have to sort of include in your management principles is that if you have a staghorn calculus, these often need the big surgery, the percutaneous nephrolithotomy, right, where they put a rigid scope into the flank and have to, essentially manually break that stone and suck it out. Okay, as opposed to the extracorporeal shockwave lithotripsy. The bigger stones require, again, a rigid scope to be placed in the flank in order to get those stones out. And that is often a feature of the management of struvite stones. Struvite stones, you really need to clean them out. Having stone fragments puts them at, because they're often infected fragments, puts them at risk for chronic colonization by that urease expressing bacteria. And as soon as you stop the antibiotics, bacterial overgrowth recurs, urease expression increases, and then they form their next struvite stone. So many times, again, struvite stone formers also need the full clean out with a percutaneous nephrolithotomy through the flank. Okay. Now we use lithotripsy, either laser lithotripsy or ultrasound lithotripsy for certain types of kidney stones. I don't know that we need to go deeply into that. Okay, let's move on to medical therapies for stone management. Looks like we're doing reasonably well on time. I can make it to the end here. So again, I monitor stone burden radiographically as well as symptomatically, right? That's what this is saying. Use your KUBs, your renal ultrasound, and then your CT scans to periodically assess at the two-year mark. Okay, calcium oxalate stones. I'm managing with always increase urinary volume is the management of all your kidney stones. The less mass per unit volume, the less likely they are to precipitate, regardless of the solute. Okay, said a different way, I'm often in counseling patients to try and motivate them. If it doesn't matter what your calcium excretion rate, your citrate excretion rate is, the type of stone that you have, if your urine volume is the size of an ocean, you're not going to form kidney stones. So even though, and I often use the analogy for sort of the age-appropriate audience, if you've ever tried to make rock candy at home, one way to sabotage that fun, kids experiment is you just put too much water in there and you'll never form the rock candy, the crystals of sugar that make up rock candy. So, I think I generally use those visuals in order to motivate the patient because, they're really hoping to come to you to say, you're going to tell me something more than my grandmother told me, right? Drink more water, and so you have to really still emphasize the point that, your grandmother is a wise person, and let's motivate ourselves to get there. Okay. Low sodium intake is certainly a factor in calcium oxalate stones, especially because of that interdependence between volume expansion and calcium excretion rates, right? So this is especially to manage hypercalciuria. Let me emphasize this point. There's a randomized controlled trial looking at thiazide usefulness. It's called No Stone, and it's a New England Journal paper within the last 5 years. And it was a negative study that said thiazide diuretics do not help with calcareous stones, which was a big kick to the gut. But we all still use thiazides to treat calcareous stones. And so the criticism of that study is that, well, some of these patients were on HCTZ as opposed to long-acting thiazides like indapamide and chlorthalidone. So when I use thiazides, I'm using the long-acting thiazides. Okay. And then the other is that the sodium intake of these patients was not low enough in the No Stone trial. And so you have to pair thiazide diuretics, and I use long-acting thiazide diuretics, with low sodium diet in order to get meaningful drops in urinary calcium excretion rates. Okay. Said a different way, if you put someone on a thiazide plus high salt diet, urinary calciums will not get better. All right. Animal protein intake can be moderated. Okay. Reduce urinary oxalate. Remember, I told you in our prior discussion, these are your sort of second and third tier interventions. High urinary volumes, lower sodium intake, plus or minus thiazides are going to be your top 2 to 3 interventions. Reducing animal protein, I think that should be moderated. Just in general, I think we eat a lot of meat, and so you can make arguments that that's good for a lot of reasons, including if you're a tree hugger. And then reducing urinary oxalate would be something that you should reserve for sort of third tier, unless it's astronomically high. And sometimes you'll see people with astronomically high urinary oxalates if they're overdosing on vitamin C, if they're taking in some of these weird diets. I've had patients who are on like huge amounts of nuts in their diet and spinach, and they have some kind of routine of doing some kind of a smoothie with all of these vegetables in it in the morning. And actually, I think there was Orson presented us a case of somebody who did what are these called? There's these clean outs that, there's colonic clean outs that certain people do, enemas and things like that with like vegetable juice and stuff. So you can see some weird things happening where urinary oxalates can be quite high. Okay. So if you have malabsorption, like again, a bariatric Roux-en-Y surgery, then obviously you can't correct an anatomical manipulation. But if you have other reasons for them to have malabsorption, so for instance, fat malabsorption from something that's modifiable, give them their pancreatic enzymes and reduce their malabsorption if you can. We've discussed how fat malabsorption increases urinary oxalate absorption from the gut. And then you might reduce their dietary intake of oxalate. Okay. And there's a lot of healthy foods that have oxalate in them. Some of the shorthand, history that I utilize in the clinic is, some of these more common things like almond nuts, spinach, and potato skins. Those are things that end up in many people who are pursuing a healthy diet. All right. And then you might even consider increasing calcium intake in the patient who has enteric hyperoxaluria. So you're trying to bind that oxalate in the gut. So if a patient has a Roux-en-Y surgery, you may actually put them on calcium supplements to reduce their formation of calcium oxalate stones, right? So calcium binds the oxalate, making it less available for intestinal absorption. So again, even though it's counterintuitive, you may treat a calcium oxalate stone former with calcium supplements. Okay. Calcium citrate, if you're going to use calcium supplementation, is probably a good choice because even though we don't think of it as being a source of citrate or base, it is a source of citrate. Calcium carbonate is a base load as well. However, it's a less bioavailable base load. And so calcium citrate might be a better choice, especially if you're trying to increase the urinary citrate excretion rate of the individual. So using calcium citrate might be especially beneficial. Okay. Target calcium intake in this sort of normal range, 1,000 to 1,200 milligrams. I believe I sent to you the paper that came up in conversation of why, maybe dietary calcium is preferred over supplemental calcium. But I told you that maybe that's just kind of a, just bias from an analysis of this study that showed some downsides of calcium supplementation. Okay. Now, if I have hypercalciuria despite low sodium intake, again, that's when I'm initiating a thiazide. There are other things that can actually drive urinary calcium excretion rate, and that's simple sugar intake. So a lot of sugary foods, the candies and the colas, they should ideally be taken out of the diet or at least limited in somebody who has hypercalciuria, whether that's proven through, clinically relevant endpoints. That is not. We don't have the data, but there is some basic science or some integrative physiology studies that show, if you sugar load somebody, their urinary calcium excretion rates go up. Urinary citrate is another push point in trying to reduce kidney stones. I certainly should try and correct a metabolic acidosis if that's present. That itself can be sufficient to increase the citrate excretion rate. And then I can do that either through correcting the chronic diarrhea, right? If you have a chronic diarrhea, treat that, give them their anti-motility agents, right? Even though that's not in the list of how you manage kidney stones, if somebody has chronic acidosis, including high ostomy output, your treatment should be Imodium, right? Because it makes sense at the level of the pathogenic steps, right? And then consider adding base to the appropriate patient once you've reduced intestinal, bicarbonate loss, okay? And I can consider allopurinol. Here we are in sort of fourth and fifth tier interventions. If other treatments for calcareous stones are failing and I'm hyperuricosuric, we've mentioned the fact that uric acid can predispose to kidney stones by a number of proposed mechanisms, one of which is what we call salting out. The more solute you have of species X, the less you're able to solubilize species Y, right? Just by salting out, competing for, let's say space in that solution by more and more solute being present. And then there's forms of uric acid that can actually functionally reduce the availability of stone inhibitors in the urine, okay? Supersaturations can be one, let's say, tool to guide therapy, right? As I'm reducing calcium excretion rates, increasing citrate excretion rates, decreasing oxalate excretion rates, right? I've said that several things there. Reduce calcium, reduce oxalate, increase citrate, then those would all, or each individually, tend to reduce the supersaturation, right? That just essentially makes the solution more soluble for calcium oxalate through any one of those interventions, okay? And it turns out even if my urine pH is a little higher, my supersaturation comes down as well in a calcium oxalate stone former. So all of those things affect the supersaturation. High urine volume also reduces supersaturation. So you can use this as a sort of a surrogate goal for the calcium stone former. Know your units. This is in the typical lab where they'll call a supersaturation over 5 to 10 as being correlated with stone risk, right? In our lab, you'll see supersaturation ratio greater than 2 as being correlated with stone risk. So it's a different set of units. You have to know your lab units, okay? But the Litholink lab, Quest lab, which is now bought Litholink, the typical normal is, or the typical, normal is less than 5 to 10, okay? In our lab, it's less than 2. Relative supersaturation refers to the supersaturation of your patient compared to non-stone forming people, okay? You and I probably have a supersaturation greater than 1. And yet, hopefully, we're not forming stones, okay? I haven't had my KUB, okay? All right. Okay, all right. All right, so in any case, we want to, again, try and lower that supersaturation. There's some weak data that lowering your supersaturation less than 3.5 or so confers a lower risk of recurrent stones, okay? And again, some labs, I guess here I put it, report data as a fold change. And in that case, you want your relative supersaturation to be less than this 1 to 2 range, okay? Moving on to calcium phosphate stones. Again, similar things that you're going to do. I'm going to increase my urine volume. I'm going to reduce my urinary calcium excretion rates through low sodium diet plus or minus thiazides, right? All of that should make sense. I'm going to correct potassium depletion. Okay, we ended on that concept last time. We said, Kelly outlined for us how if I have potassium depletion, I have intracellular acidification. And if I have intracellular acidification, I upregulate citrate lyase. I increase the reclamation of citrate from my urine. Okay, so treat a K deficiency aggressively, including that K deficiency that you may have caused with the thiazide. Okay, so not everyone should need K citrate. Sometimes it's just K chloride, right? Because by giving K chloride, I may increase your citrate excretion rate without causing alkaline urine, right? So calcium phosphate stones, the reason that's so difficult to treat is that the one tool that we have beyond the well, we have various tools. We have urine volume, we have reducing urinary calcium excretion rate, but beyond that, K citrate is very much a double-edged sword. Okay, you're trying to use K citrate to correct any metabolic acidosis, and that will potentially help the hypocitraturia. But if you give too much, you're going to make the urine more alkaline, especially in the context of a RTA patient. RTA patients already have a urine pH that's 7 or more, right? And so if you give them potassium citrate, even though their bicarb is still went from 18 to 20, right? You didn't cause metabolic alkalosis. You moved their serum bicarb from 18 to 20, but their urine pH went from 7 to 7.5. Okay. If you look at what happened with the supersaturation can be worsened by that, even though your urine citrate went up. Okay. The net result may be a urine supersaturation that's worsened because you also made the urine pH go up. Okay. Naeem Malouf, one of our senior investigators here, has specifically published on calcium phosphate stones, and he has shown that the most important predictor of recurrent stones in a calcium phosphate stone former is what is the urine pH, not the citrate excretion rate. So if you believe that data, and I have no reason not to, there's plenty of downsides to K citrate. Okay. All right. So you have to find some way to increase urine citrate excretion rates, but without increasing urine pH. And definitely closing any K deficits is one of those tools you should use. Okay. With KCl, not K citrate. Okay. All right. And then again, if I'm using supersaturations to try and target my treatment, I'm trying to get those supersaturations less than 1 in a calcium phosphate stone former if I'm able to. The uric acid stone former, familiar guy, remember grandma's right, high urinary volumes, but the other is get the urine pH up a bit. Okay, don't try and go over 7. Getting it to 6.5 should be sufficient. Okay, and you can do that with either sodium or potassium alkali salts, right? You can use sodium bicarbonate. You can find potassium bicarbonate, although it's harder to find. And then potassium citrate is another tool that we are using, okay? Now, if you're going to use a sodium salt, you should certainly watch for the development of hypercalciuria, keeping in mind that, sodium bicarbonate doesn't have all that much salt, right? Each tablet has 7 millimoles of sodium in it. Allopurinol is used sometimes, but most of the time, urinary alkalinization is sufficient. And again, these are the ones that can be dissolved, that may not even need lithotripsy to break them up and excrete and extract them. Struvite stones. Here we are approaching the end here. Stay with me if you would. Struvite stones, infection eradication is key, okay? And often I need to do the percutaneous nephrolithotomy in order to get all the stone fragments out in order to reduce the likelihood of reinfection. Okay. When there are those persistent fragments that can't be removed for some reason, you can consider things like chronic antibiotic therapy. That does breed resistance, though. Okay. The other is actually the use of a urease inhibitor. Okay. We don't use that very often, especially hydroxyurea, because of the obvious downsides of bone marrow suppression. But there is a drug, acetohydroxamic acid, that is prescribable as a urease inhibitor. I would never use hydroxyurea. If I did use this intervention, I might use acetohydroxamic acid. I should add here, because I've even used it and it is in the literature, certain scenarios of calcium phosphate stones may be treated with acid loading. So people have published it using methionine supplements to try and lower urine pH. Okay, methionine is a sulfur-containing amino acid, which is an acid load. It's as if you took in your big steak without having to eat a steak. So it is a skillful move, right? It's not something that you'll find commonly, but it is published for the refractory calcium phosphate stone former who doesn't already have a mean metabolic acidosis. You may actually consider acid loading some of these patients. Okay. The scenarios in which I've used it is in certain patients with a variety of syndromes, things like cerebral palsy. I have a patient with Rett syndrome, believe it or not. And these patients, by virtue of the fact that they have kind of altered diets, they're on tube feeds, they have sort of weirder urine chemistries, and they're not acidemic, or they don't have metabolic acidosis. And I just need to acidify their urine. I've actually added methionine to their regimen. Okay, moving on to cystine stones and finishing out there, we would want to increase fluid intake. We want to get the urine volumes up. And then I want to target a lower urinary cystine concentration, okay? Or I can use the cystine supersaturation if I can get that data. We now have, more commonly, we're following a different parameter called cystine binding capacity. What is a cystine binding capacity? It's essentially the old school methodology that I talked to you about last week. We don't do this experiment when we calculate supersaturations, the experiment of letting urine equilibrate with some solid a salt in that urine and reaching solubility point and measuring the change in concentration at time zero compared to that equilibrated phase. Okay, that's what you do with cystine binding capacity. Essentially, you do the experiment, and so you have a urine. So you have a urine, right, that has a amount of dissolved cystine in it, cystine dimers, right? All right. And then you have some known solid quantity of cysteine in the sample. And then you measure the change in concentration essentially from time zero to the equilibrated point. If it is supersaturated, then this grows, the solid component grows, and the concentration of dissolved cysteine decreases. That difference in concentration describes the cystine binding capacity of the solution. Now, you can change the cystine binding capacity by making it more dilute, but another way you can have a reduced, you can change the cystine binding capacity is by giving drugs like Thiola, which is basically a drug that competes for this dimerization of cysteine, right? The Thiola or binding drug binds with the cysteine, so it'd be less likely to dimerize. And that would potentially favorably change your cysteine binding capacity, right? You want a larger cysteine binding capacity that correlates with a reduction in stone events. Okay, so you'll get that result in you can send that urine study in patients as a measure of success in your cysteinuric patients. Low sodium diet again reduces cysteine excretion rates. Potassium citrate makes the urine more alkaline, which makes the cysteine more soluble. Low protein diet reduces the cysteine excretion rates, right? Because animal proteins have more cysteine in it, and then also tends to make your urine less acidic, right? Then I have the thiol drugs, if that outcompete cysteine dimerization. Um, Teopronin is the generic name. Thiola is the trade name for this tool. And then we have older options that are really not used very often. One thing that you need to be aware of is that all of these thiol drugs will have a risk of causing a drug-induced membranous nephropathy. It's been associated with all of uh, um, these drugs that have a chemical structure that allows them to bind cysteine. So you should monitor for proteinuria when you start these drugs. Okay, questions?